Finally, some words about the validation. You can ask me, okay, this is a new method, newly patented method, quite nice, so simple, very good, but could you show me some kind of validation? Ladies and gentlemen, let me tell you, honestly and frankly, if you go to the internet search, to the PubMed, I can assure you that today, the best validated device, according to the scientific literature, is the arteriograph. Interesting. Please do so. Please put to the internet and to the PubMed validation of sphygmocore, validation of complier, or validation of the arteriograph. Most of the keywords will provide this study, which was published last year in the Journal of Hypertension, comparing sphygmocore, which is the tonometric device, and piezoelectric device, which is the complier device, reflecting their excellent agreement with each other, but, which is the most important result, the variability and the reproducibility of the pulse velocity measurement was best for the arteriograph. So I'm a clinician. I don't care if something, let's say, +1 or +-, but I do care if I cannot repeat my measurements sufficiently with the same value. So I hate if I measure 7 and then 14. I don't like that method. So this data, power, and strength is that the variability and the reproducibility was best for the osteometric method. Although in the same year, the second part, other study, independent study occurred, and they concluded that they didn't find any difference in the pulse velocity between sphygmocore and the arteriograph. Just recently, during our meeting in February on the 5th International Symposium on Arterial Stiffness in Budapest, a study was occurred from Latina, from Italy, where the central systolic blood pressure was validated, measured during coronary angiography, and measured with the arteriograph with very, very high and nice agreement. Then, also in the International Symposium on Arterial Stiffness, a nice paper and nice work was published by Renata Lacik from the University of Debrecen. They compared the arteriograph measured pulse velocity with the carotis femoral measured pulse velocity by ECG-gated pulse wave Doppler. Please don't forget, not only applanation tonometry or piezoelectric method is good for measuring the pulse wave velocity, but also very good to measure with Doppler. If you had an ultrasound, you can measure with Doppler easily. You can see the device, the arteriograph, with the cuff, and you can see the setup of the measurement of the femoral and the carotid artery. So 31 patients were measured, and the mean age was 43. The device, as I mentioned, and here you can see the agreement, which is not surprisingly quite nice, as the former studies showed, that they found a very nice correlation between the ultrasonographically determined pulse wave velocity and the arteriograph measured pulse wave velocity. In my university at H, we have done some invasive studies, which are under publication. The study first was aimed to check whether the intra-arterial, intrabrachial invasive curves, how do they fit the non-invasively recorded curves. So this is the setup, this is the needle signing and marking the upper edge of the overpressurized cuff. This is the cannula into the brachial artery from the radial insertion. This is the study setup. You can see the pressure sensor of the arteriograph and the pressure sensor of the invasive unit. And then this is the suprasystolically inflated cuff. And then you can see the intra-arterial measurement at stop flow condition. Don't forget the flow is stopped because of the suprasystolic pressure. And this last bit was duplicated by the non-invasive measurement, which is quite impressive. And then we controlled on the 75 cases the agreement between the invasively and non-invasively recorded brachial curves, which proved that not only the visual but also the statistical agreement is quite high. Then we controlled the aortic augmentation index from the coronary angiography and the simultaneously measured brachial augmentation index. This is the Bland-Altman spot. You can see it's very nice. And also you can see this curve in the Spellman agreement we found the linear correlation between the aortic and the brachial augmentation index. Finally, we measured the pathway velocity of the aorta and then the pathway velocity of the arteriograph device, which showed also a very good agreement, and this is the Blum-Dartman plot. Only one was out of the 2 SD, all of the other examinations were within. So the final question came up, whether this method, which is advocated and suggested by me and for the scientists for the general use, for the primary care use, for the screening use, for the population screening, because of its simplicity and user-independent operation, whether it's useful to screen for asymptomatic macrovascular atherosclerosis. I started with the atherosclerosis, I finalized this one. This was the reason why, with my PhD student, with Renato Böcskei and me, we started a larger project. I performed carotid ultrasound to reveal carotid atherosclerosis, blinded, so I didn't know and I was unaware of the arteriograph measured stiffness parameters. She did the stiffness parameters and then we measured the results. And this is the patient characteristics. More than 600 subjects were inside. Now we are above the 750, and then we start at 1,000 to be able to split subgroups. The age is middle age, quite normal blood pressure, and what was my surprise, the carotid positivity in this age group, it's nearly 50%. Which, in its accordance with my four first slides, you remember that the atherosclerosis in its asymptomatic form is very, very common. Carotid's protocol was based on that because I considered to be atherosclerosis and the plaque if the calcificated plaque was seen at least 1 millimeter large, echogenic, which is shining, like the light was shining, or at least 1.3 millimeter IMT was measured. It is very conservative estimation, but I wanted to be conservative in this estimation. The stiffness protocol, I don't want to deal so much with it. It was written and was done according to the guidelines. The receiver operating curve showed a very interesting case. We know all well from the guidelines of the European Society of Hypertension and European Society of Cardiology that the guidelines said the threshold to be 12 meters per second. And much to our surprise, we have seen and we have received much lower cutoff line. It was 9.62. And then if you ask me a question why this so, after my talk I can explain to you, it's much more simple than you think in advance. Briefly, just a distance issue. And then if we used this cutoff line as a threshold, we could see a very nice sensitivity, quite good specificity, good predictive value, and positive and negative, and quite good relative risk and odds ratio for this. I don't want to say that this study is everything, but much more than nothing, and the more than 600 subjects is quite a big number, which means that we are very happy if any of you would join us in performing this study, probably in more advanced way. But which was interesting to me, I have found a quite big number of the false positive results, which means that I measured high pathway velocity and we didn't find carotid plaque. I suppose, I hypothesize, this is not free subject from the atherosclerosis, but it may be so that the patient may have coronary atherosclerosis. To be honest, I don't know, any of you would know, I would be happy to your answer, the strict relationship between the carotid and coronary atherosclerosis. So I guess that they may play alone, not all the time they go together. So briefly, the more I deal with the atherosclerosis, the less I know. So it's a fact. So what we conclude as an indication of the artery stiffness measurement and artery function measurement, to screen for early undiscovered asymptomatic atherosclerosis, preclinical atherosclerosis among apparently healthy subjects to improve the cardiovascular risk assessment. Ladies and gentlemen, I don't say that throw it away through the window, all of the methods, even the Framingham or many other methods, not to use them. I'm far from to say that. But I do say that you can improve your risk assessment, at least among those who are in the intermediate risk category. And the guidelines doesn't help you what to do with them. This is a big indication for the arterial function evaluation. And furthermore, on the basis of the CAFE study and other studies, it is excellent tool to assess the action of the drug on your central hemodynamics, to reveal the effect of the drug on the systolic, central systolic blood pressure and the augmentation index, even with disease subjects. Take care. The arterial function evaluation will never detect a stenosis, a local stenosis, will never replace the coronary angiography, because it doesn't tell anything about this issue. So the big question marks comes up. Okay, we know all that the augmentation index, central systolic blood pressure, aortic pulse and velocity goes together with higher number of the cardiovascular events, and this is a very high risk factor. But the question comes up, if we could treat the increased augmentation index or increased systolic blood pressure or increased pulse rate velocity, would that be useful? We don't have data yet. And this is the reason why I'm so happy to announce you that last week we agreed in London, and the Barts Hospital and the George William Harvey Institute, that we are about to finalize a HUNT study, Anglo-Hungarian polypid trial study, in which we would like to measure as much as 350,000 subjects, because this method allows us to do so. We would like to equip a region, altogether 600 GPs with this method, and then we would like to collect the data, which can be done quite easily. And my university will be the knowledge center, the Page University, and also the same will be set up in London, in a poorer district and in a richer district. And we would like to partly compare the two different medical background society and the country value. And also, we would like to step further for the polypill administration. Just recently, the Lancet published the paper, because we have to say something, what should we do if the augmentation index or PWV is high, but other parameters are normal. This is a trial in which I would see that it could be a beautiful place even to Sweden, for Sweden, and I think so that my English colleagues would not be against and object to you, so we could spread away. The mission of the study, we would like to give a very bright and very powerful statement and data for the European Union, European community, how to handle the arterial function evaluation in large scale, in the population-based manner. How could it help us to improve the cardiovascular risk assessment? Finally, I would like to say many thanks for your attention. Thank you.